Good morning, everyone. Welcome to this roundtable discussion on the recent studies in CTO PCI. I've got a fantastic bunch of friends and colleagues who I'm very happy to introduce. We have Jo Dens from Belgium, Chris Buller from Canada, Margaret McEntegart from Scotland, Simon Walsh from Northern Ireland, and Evald Christiansen from Denmark. So we're just going to get down to it and start talking about the studies. And Margaret, I'll hand the floor over to you. The title of your discussion is a critical appraisal of DECISION-CTO and EUROCTO. Thanks, Margaret.
Thanks, James. So what I'm going to do is do a walkthrough of the two trials and discuss them in parallel to stimulate some further discussion around the table. So the first thing to say is that this presentation is obviously based on the slide presentations of the two studies at the ACC and EuroPCR, because the papers as yet are not published and available for analysis. So the first thing to think about is what the hypothesis of the two trials was. So in DECISION-CTO, the hypothesis was that optimal medical therapy would be inferior to CTO PCI according to MACE at 3 years. Whereas in EuroCTO, the hypothesis was that CTO PCI would significantly improve the health status at 12 months according to Seattle Angina questionnaire assessment and would be safe compared to OMT at 3 years, safety being defined as the rate of death or MI. If we look at the design of the two trials, both were open-labelled RCTs. DECISION-CTO was conducted entirely in Korea, EuroCTO being in 26 centres across Europe. All the patients in EuroCTO had angina, stable angina, and DECISION-CTO, 25% of the patients had ACS. If we look at the recruitment figures, the target for DECISION-CTO was nearly 1,300 patients. They actually recruited 815, and this took them 6 years. In EuroCTO, the target for the 1 year endpoint was 600 patients, needing 1,200 for the 3 year endpoint, and they actually recruited 407. This took them 3 years. And of note, it was in the presentation at EuroPCR, they reported that the recruitment to screening ratio was about 30 to 40%, so they struggled with the recruitment. As we mentioned before, the primary endpoints were MACE at 3 years for DECISION-CTO, and there was two primary endpoints for EuroCTO, Seattle Angina questionnaire, health status at 1 year, and death and MI at 3 years. So if we look at the demographics of the patients in the studies, quite strikingly, there's a low rate of previous MI, PCI and bypass in DECISION-CTO. There was about a third of the patients had diabetes in both trials, and 50 patients had single vessel and multivessel disease in EuroCTO, while there were 3/4 with multivessel in DECISION-CTO.
It's worth a moment of discussion just on those sort of different demographics. So within our CTO PCI population, we have 30% who are post-CABG. A lot of them have multivessel disease, but I think the DECISION-CTO, which you'll probably touch on, population had a high amount of other non-CTO vessel PCI, which is undefined, and that is a major confounder in the data, I think.
Yeah. Thanks, Simon.
The low rate of prior MI is also curious. When I saw that, I pulled out a range of prior studies going all the way back to the first Tosca study all the way through until EuroCTO. And at 10%, it's the lowest. The next lowest is EuroCTO at 21%.
Yeah.
Most studies are in the range of 35 to 60% prior MI, and it really makes me question, frankly, how many of these were chronic.
Yeah.
Yes.
Mm-hmm. And I mean, within that population as well, I mean, obviously it's a group who are of less complexity, but it's certainly a group who are patients who have less disease.
Yeah.
But the MI question is really a question of definition. Most of the time this is done on history. Mm-hmm. The studies that you quote, I mean, the highest rate was an MR-based study quoting a rate of 80%.
Right. But on the history alone,
on the history alone,
it's most unusual to see a rate less than 35%.
Yeah.
Correct.
Particularly in the context of them reporting diabetes in a third.
Yeah.
There's a real disconnect there between those demographics. Mm-hmm. So if we look at the CTOs themselves, the mean JCTO score in DECISION-CTO was reported to be 2.2 to 2.3, and in EuroCTO 1.7 to 1.8. Success rates look impressive, 91 and 86%, and a quarter of the patients in DECISION had a retrograde approach, with over a third in EuroCTO having a retrograde approach.
But it's also interesting, they quote a 91% success rate. Actually, the number of CTOs that were attempted were much lower, so they didn't even attempt 15%.
Yeah.
So their actual success rate in the CTO group was about 76%, of which most of it was antegrade wire escalation. So it's very much a sub-selected group of straightforward lesion.
Yeah.
And there is also a further disconnect there, Simon, isn't there? When you're suggesting your JCTO score is approaching 2.2, and your success rates are 91, yet your retrograde, use is only 25%. That's quite markedly divergent from our data.
Yeah, absolutely. This is completely different from Recharge and from the US data and from your UK registry data. The GCTO score is much too high for a low retrograde approach.
Yeah. Importantly, if we look at the crossover data, so there was an 18% crossover in decision from medical therapy to PCI. This was 7.3% in EUROCTO, and probably lower, I think, because there was a slightly more robust mandatory enforcement of medical therapy in EUROCTO and this wasn't present in DECISION-CTO. There's significant amounts of missing data, particularly in DECISION-CTO, up to 17% in one of the arms of the trial for the primary endpoint, with 9% missing even in EUROCTO. And this is obviously something that we really need to take into consideration.
I had a great deal of difficulty as I looked through the slides and re-listened to the presentation and differentiating the crossover from PCI to OMT, differentiating crossover from a quietly failed procedure.
Or actually not attempted.
Or not attempted. But well, that would be the true crossover.
So a substantial amount were not attempted.
Yeah.
And of those that were attempted, then the actual failure rate was quite low. So if you take that group as a complete amount, it's about 25% of the PCI group did not have a PCI. The OMT group, I think that number is correct, isn't it? The 18% didn't have OMT. They crossed over to a CTO PCI with a successful PCI.
Yeah. So if we look at the results, so starting with DECISION-CTO, this was the primary endpoint in MACE as intention to treat. And as you'll have seen the Kaplan-Meier curve, there was no difference between OMT and PCI at the 3-year outcome. Looking at the pre-specified non-inferiority margin of 0.7, OMT was found to be non-inferior to CTO PCI.
So this is, for me, statistical hocus pocus. So it's not actually what the original hypothesis was in terms of the endpoints. And to have a statistically significant, with the p-value number coming out, with a difference between the two treatments of 30% is something that I think is not actually valid to patients. And I think this is also important within trial reporting, that people understand that this type of difference is enormous. To say something that's not 50% or 30% different to something else doesn't really mean much.
Yeah, I agree. I think the non-inferiority margin 0.7 is quite strange in the statistical design.
Well, basically what it means is that they're trying to get a p-value for numbers, and that doesn't mean anything.
Yeah.
Apart from the statistics, the big question is, was the primary endpoint well chosen, and the population which was selected, was that well chosen? There must be, first of all, a bias in the selection of patients. Also, in decision, it took too long, in fact, to include the patients. I think if we want to have a good trial, it should be a trial where non-CTO operators or referred patients who are randomized. So it's not up to us to randomize the patient, because then already you create a selection bias. If you know the patient and he has a lot of symptoms, you will be reluctant to randomize that patient. Some operators maybe will look at the angiographic characteristics and randomize or not based on the angiograph. That's what we discussed, if you include only lesions. And here I think one of the concerns is that a lot of ACS patients were included.
Yes.
And this has an important impact on MACE, of course. And the question is if the MACE is still driven by the CTO or by all the other lesions and all the things which are around.
Yeah.
But I mean, around this table, we've got a group of operators who between us will do 1,200 CTOs per year, and they randomise 6 patients per centre per year. Yeah. In the last 3 years in Belfast, we've put over 300 patients into CTO trials.
Yes.
And I think that is of some import as well, that they,
for sure.
they had a highly selected population.
But just to go, Evald, can I ask you this question? And because one of the best things about the recent left main study is that doctors, physicians can take away an understanding of who the patients were in that study and the applicability of that study to their patient. The bit I'm struggling with both these studies is how applicable it is to my population. So any comments on that and the lack of a registry arm here, for example?
I think if we calculate 7 patients per year per center is included. So there's really a selection, and I think it's selection of patient where the patient does not, it doesn't matter for the patient if he gets the medical treatment or the PCI, and for the operator. So it's really a selection of patient where you don't mind it. It's also reflected in the crossover because they're not treated when they're randomized to PCI and vice versa. So I think they are not representing the CTO patient I see today.
Yeah.
This is really a selected group of patients. And I'm also not sure that this primary endpoint should be a primary endpoint in a CTO trial. I think for me it's more a safety endpoint.
Yeah.
And for me, this shows that it's safe.
Yeah.
And even though it goes in favor of less death, it's not significant. And if we go further and look into the untreatment, where we take away some of the bias from the crossovers, the patient do not get the treatment they're allocated to, there is a trend towards survival benefit. So for me, when I see this trial, this could be our safety trial, and it's really a safe procedural.
Yeah.
Spontaneous myocardial infarction is not increased.
Yeah.
You have an open vessel where you can have a STEMI, you can have an occlusion, there's been all this discussion of what happens to the collaterals by time when you open the CTO, will they turn down, will you lose the protection if you have reocclusion? But spontaneous myocardial infarction is exactly the same. So for me, this study shows it's safe, and then when we come to euro-CTO, this is the primary endpoint. We open the vessels to improve symptoms. Can we do that safely?
Yeah.
So if we add those together,
I'm going to take a different tack on this because I think that it's a little unfair for us to say that we don't know who's in the study and what was the nature of the occlusions and who are these patients, and then to pick out the part we like, which is safe. I honestly don't know if this shows safety because I have no idea who these patients are. So I don't know if this applies to the safety of the patients I do, to be honest with you. And I'm very suspicious that the patients in this study don't look anything like what my typical week looks like. And I'd be hesitant, therefore, to extrapolate on the safety message.
Yeah, no, I think that's a fair point because one of the criticisms we're saying is that this patient looks like a not very complex population, and it may well be that if there is a safety price to pay, it's in a more complex population. Certainly, with an instance of bypass that you touched upon, Simon, of 1% compared to our experience of about a third of
Which
bypass.
is where we see our complications. Certainly in our site, it's the prior bypass patients.
1% post-cabbage does not reflect any population of CTO patients in Western Europe. I mean, it's between 20 and 30% for people who are doing chronic total occlusions that are referred to them. If you actually get the enriched referrals, then you're probably up to 40%, and I think that is a very, very different population in terms of our practice, and we're approaching 40% of people who have graft failure, high symptom burden, and no other options other than a CTO PCI to make their quality of life better, and 1% I personally don't understand.
We've seen this in the kind of comparison between the Asian population, which does have a lower incidence of bypass surgery, and the Western population, which doesn't before. But I never think I've seen a study where the rate has been as low as this. I mean, JC2 score was 9%, something like that. But 1% is astonishingly low.
And again, when we look at the registries, in fact, the higher complication rate is in those patients where you need a retrograde approach because of the patient profile, often post-cabbage, but often these patients are more sick than the one where you apply an antegrade approach. So having a low retrograde approach, again, decreases in fact the risk and reduces the concerns about safety if it's more antegrade wiring.
Another important point is also this procedural myocardial infarction included in the endpoint, because in euro-CTO we did not see, because in our definition the patient should have symptoms. In DECISION-CTO, an elevation of factor 5 in CKMB was enough. This is not even the SKY criteria.
No.
And if you do a CTO procedure, what is the importance of a CKB elevation of 5 times when it's not reflected in reducing left ventricular function, if there's not symptoms, if there's not ECG changes. And this is 10% of the 25% of the... Why do they get this in the definition of procedural myocardial infarction? I cannot find it in the literature. This is in 5 times.
And the other question you have to ask is, how can an OMT group have a rate of type 4A MI, which is almost equivalent
Yeah, that's the
to a
crossover.
PCI group?
This must be a calculation in the crossover.
It's not the crossover, it's other PCI. So if you look at 7.6% of the entire OMT population, it's actually from PCI for other vessels.
Yeah, well, they had an average of 2 stents per patient in the OMT arm.
Which is a very high rate for procedural MI.
I mean, OMT, sort of nitrate, nicrandil, 2 stents.
Important difference because
Well, they're drug coded.
in euro-cto trial, these non-CTO lesions should be treated before randomization. Here they could do it in the same procedure, and there's really noise in the...
That's again the problem with the population studied. It's again the population which was studied there. That's the problem. Too much other lesions, not
Better let
focused on
Margaret finish.
CTO, ACS patients.
So as we've been discussing, when you break down the primary endpoint from DECISION-CTO, it's quite interesting what you see. So the death rate in the PCI group's less than in the OMT group. And as we've just been discussing, when you take out procedural MI, the spontaneous MI rate's the same in the 2 arms. There's more stroke in the OMT arm, and there's a little more revascularization in the PCI arm. Just out of interest, I thought I'd look at the 12-month clinical outcomes in EUROCTO. This is obviously not powered, but just to see how this compared, and you can see that the MACE rate was actually lower in the PCI arm. And when you look at revasc, because this was ischemia-driven revasc, it wasn't all revasc, we actually see that the revasc rate is lower in the PCI group.
But Evald can speak to the 3-year rates of repeat revascularization in the NOBLE study, which was left main and multivessel disease. And I think the 3-year rates of revascularization in NOBLE are actually lower than the repeat revascularization rates in the optimal medical therapy arm of DECISION-CTO, which is what it is.
It was 15%,
15%, sorry,
in the PCI arm and 10% in the capital arm.
At 3 years.
5 years.
5 years. 5 years.
Yeah.
So actually the repeat revascularization rate at 1 year in the OMT arm, which in theory should never have had the possibility of a repeat revascularization within DECISION-CTO, was approaching a 5-year rate of revascularization within NOBLE, which is somewhat bizarre.
Do we have any explanation for the difference in stroke, Margaret?
No, they don't offer any explanation for that.
Because you expect if you do more manipulations that you have
You would
an
think so.
increased risk of stroke in an intervention group, and from the other hand, maybe there's a difference in medical treatment.
We saw a difference in stroke between CABG and PCI and NOBLE, and I mean, it was
Do they get more clopidogrel in the PCI? Because it could be protecting against some ischemic stroke.
But then the medical treatment is again also different.
Yeah, it's got to be the play of chance as the predominant factor.
I think it's play of chance, mainly.
which it definitely was in NOBLE as well.
Yeah.
So if we go to the primary endpoint of EUROCTO, which was health status by Seattle Angina questionnaire, what they found was that, or what Evald and the group found was that everybody's symptoms improved at 12 months from baseline, but this was more significant in the PCI group than in the OMT group, with higher scores meaning you're less symptomatic. If we go and look at the DECISION-CTO, they had this as a secondary endpoint. It's really important here to say that in the data that's available from the presentation, that there was a huge amount of data missing, up to 50%. So we have to interpret this data very cautiously, but they found no difference between the PCI and the OMT group.
And I think we need to emphasise that they treated the data quote unquote as missing at random.
Yes.
I think they replaced missing data with the mean of their nearest neighbour, which in essence means that 50% of the numbers in this endpoint were actually filled in. So how do you interpret that? Personally, I don't think you can.
Yes, that's an important point, Simon. So obviously missing at random suggests that the patient's health status hasn't influenced them returning for follow-up, which obviously we all know would influence them for returning for follow-up.
But there's a statistical definition also when you can still do that. If there are too much data missing, you can't do it.
But I mean, 50% is...
Yeah, that's huge. I mean, You cannot correct anymore for
It's
that.
half.
Yeah.
It's kind of a lot.
Yeah, it's clear you cannot do it.
If you have low quality of life, you're not prone to fill out those papers for the hospital.
Too exhausted, do you think?
I'm not happy with the treatment in this
Too
hospital.
much chest pain there.
I want to. It gives me chest pain.
I would come to complete your survey, but I get this central crushing chest pain.
If we look at this and a couple of the parameters just a little bit more closely, a couple of things also to point out is that at baseline, the DECISION-CTO patients had less limitation. So they had higher scores at baseline for some of the parameters, suggesting they were less symptomatic, which would be in keeping with some of the other points we've discussed. So they had less physical limitation and they had less endurance.
I mean, personally, I think that's a very important point in that the people who are randomised are actually the people who've probably got occlusions that are less important and a situation where they're much less symptomatic. And if you gain randomisation at that point, the likelihood of finding a difference, either in terms of hard endpoints or in fact quality of life endpoints, would be much reduced. So I think selection bias here is very, very important.
There's another aspect to this which I think is worth at least considering. It may not be valid, but one explanation for the high baseline scores is that they're minimally symptomatic. Another is that the SAQ, which is an American score developed and validated in the US, may not be the right instrument to measure symptoms in Asia.
Yeah.
You know, there are cultural overlays to how we express ourselves. We know the differences with respect to the predisposition for surgery. There may be other, inherently stoic qualities to the Koreans that means that reporting baseline symptoms is not actually valid with this score.
And maybe even 12-month symptoms. So maybe
Could
that's
be.
why they can't use that score. That's why we see no difference in N across all the groups, across all the parameters.
It may be
It's
it would
invalid.
be interesting and valuable, I think, to ask John Spurtis, who of course is the developer of the SAQ, what his thoughts are and what literature exists on
Yeah,
cultural
it's an interesting point.
specificity for the score.
Okay, so having looked at the angina burden, if we look, what do we know about ischemia in the two trials? So what we saw from DECISION-CTO was that in the overall population in both arms, only about 60% had more than 10% of ischemia. And actually in the CTO territories, it was more like 50%. So a lot of these patients did not have significant areas of ischemia in the CTO zone. In terms of what we know about this from EUROCTO, there's not as much data available about this at the present time, but we do know that the inclusion criteria for that trial was that you had to have a CTO in the HE segments 1 to 3, 6 to 7 or 11, which basically means your CTO had to be in the proximal left system on your dominant right coronary before the bifurcation. Gerald Werner, when presenting the EuroPCR, said he thought they had ischemia testing in approximately 60% and viability testing in approximately 80%, but we await that information. So as alluded to earlier on by Evald, this was the analysis of the primary endpoint from DECISION-CTO as treated as opposed to as intention to treat. So what we see here in the bottom of the Kaplan-Meier is a crossover patients. So you can see that the patients that crossed over from medical therapy to PCI did significantly better, the p-value of 0.02 compared to the other groups. So my interpretation of this would be these were the patients that actually had refractory angina, then actually returning to have it treated. So that's where the benefit lies, patients who actually have symptoms as opposed to the less limited.
Well, I mean, I think this is a very interesting data point, and for me, what it tells you is that this is actually a trial of partial revascularization versus complete revascularization, where a certain number of patients are randomized to complete revasc versus partial revasc, and then there's a crossover group as well. And actually, it supports a hypothesis that complete revascularization is better for you in terms of an absolute risk reduction in MACE, which is interesting. And there's not much around that actually shows that at all. And if you go back and think about how you randomize these patients again in future and run a trial like this, probably it's reasonable to think about PCI for non-occluded vessels and then randomization thereafter, as was done in EUROCTO. But the 7% absolute risk reduction in MACE for those who were treated by PCI versus medical therapy at 5 years is quite profound. So it's not worth sort of putting your nose up at it. I think the data are very interesting.
Yeah.
Just to throw a fox amongst the chickens, You know, it's also reasonable when you think about the ischemic burden of chronic occlusions to treat all the chronic occlusions and then randomize the non-occluded vessels.
Yeah.
That's also true. Yeah.
Interesting.
I mean, the numbers, go back, just back a slide a second, Margaret. The numbers of the PCI to OMT, how many people are in that group?
It was 16%, wasn't it?
So
Yeah.
65 patients in the bottom line, it says. 65 patients.
So they didn't attempt the CTO in a substantial proportion, and they also failed the CTO in
Yeah.
another proportion. So they quote a 91% success rate, but actually that's not quite right.
Yeah, so
It's closer to 76%, I think, of the quote-unquote PCI arm.
I mean, if you look at the spread in that group, and the devil's in the detail here, of course, and we don't know probably enough to come to a firm conclusion about who these patients are, but it would suggest that there's a significant jeopardy in these patients and whom they're sub-selecting out. I mean, the data here, as we see it, would suggest that those are the high-risk patients.
Yeah.
Yeah, it's very hard to know if that's treatment effect or some unseen imbalance in the groups. We just don't have that information.
Yeah.
No.
So just to wrap up the slides, so what do we think we've learned? Just a few points. So I think we've learned that CTO, PCI, multicenter RCTs can be done. They can be done better, but they can be done. I think we can see that it's possible to achieve high procedural success rates that we require for clinical trial validity, although obviously there's some questions about the actual nature of the CTOs that were treated, particularly in DECISION-CTO in terms of complexity. We've learned, and I think we know from other experience, that trials in complex patient cohorts can be difficult to deliver. There was issues in both these trials with profound slow recruitment, and as we've discussed earlier, this can undoubtedly lead to selection bias, where it's difficult for people to randomise patients that are very symptomatic, but by not doing so, we negate the effect of the treatment.
Yeah. And within the patient groups, again, within this sort of lesion complexity aspect, I mean, never mind the 1% post-cabbage in DECISION-CTO, 85% are done with an antegrade wire escalation technique and 1 or 2 guide wires. That does not reflect our practice in any way, where 50% of patients require a dissection technique for a complex lesion, and I think this patient group is very, very different to the patients that we deal with every day.
Usually takes me 2 hours to get to my